I think so too. Okay. Okay, health maintenance in diabetics. Health maintenance in diabetic mellitus. Glycemic control. Check A1C, HbA1c every 3 to 6 months, and goal is less or equal 7% in younger and 8 or less than 8% in older. Limited life expectancy and comorbidities. Nephropathy screening annual random urine albumin ratio. If it is normal value less than 30 milligram per gram is normal, and periodic serum creatinine level. Retinopathy examination, dilated eye examination every 1 to 2 year. Neuropathy visual inspection at each visit. Annual comprehensive foot examination, annual comprehensive foot examination, and cardiovascular risk reduction. Address lifestyle factor like tobacco, obesity, diet, exercise, annual lipid and BP screening, and aspirin statin. Okay, routine health maintenance in diabetes mellitus includes monitoring microvascular complication, annual urine albumin, creatinine ratio, annual dilated eye examination, retinopathy screening, and periodic foot examination to test sensation and vibration, neuropathy screening. These complications can be prevented or mitigated by achieving adequate glycemic control, HbA1c less than 7%, managing concurrent risk factor hypertension, and in certain cases in prescribing pharmaceutical agents that slow complication progression. The earliest sign of diabetic nephropathy is albuminuria, defined as urine albumin creatinine ratio more than 30 milligram per gram. Hypertension is an exaggerating factor when either albuminuria or hypertension is present. ACE inhibitor lisinopril and ARB are indicated to control blood pressure and slow the progression of diabetic nephropathy. Sodium glucose cotransporter inhibitor dapagliflozin also slow nephropathy progression and may be used when glycemic control is suboptimal or when cardiac complication, heart failure are present. This patient has neither hypertension nor microglobulinemia, therefore ACE inhibitor or ARBs are indicated. Next, slightly higher. Hypertension with hypokalemia. Wait, If you find a patient with hypertension with hypokalemia, what you will think? In adrenal issue, like what you are going to think? Like what kind of adrenal issue? Like you are thinking about pheochromocytoma, tumor of the adrenal medulla. Are you thinking like that? There may be think in this way, like what will cause the low potassium? The low potassium. We know that aldosterone causes uh, aldosterone aldosterone increase. It will take increase sodium and decrease potassium level, isn't it? So there may be some sort of aldosterone issue. Okay, so you have to remember this chart, like for dealing with this question you have to remember this chart, and you are choosing like chest city, like yes, but chest city for if lung cancer, isn't it? And it is SIADH. This causes this type of hyponatremia, not like hypernatremia. Okay, I will read the all the explanation. Okay, first look at the box. Just you have to remember, because I remember the flowchart, that's why I got the answer. Okay, first, if you get a patient with hypertension with hypokalemia, this is clear. Like we got a patient with hypertension with hypokalemia, then the next thing we need to do plasma aldosterone versus renin ratio. Plasma aldosterone versus renin ratio. If think in this way, like if aldosterone is high and renin is low, that means it is primary hyperaldosteronism. Not written in here. Okay, I go through this box too. Okay, plasma aldosterone and renin ratio, if it is normal, then evaluate for other causes. That means it is not the aldosterone and renin ratio, like hyperaldosteronism ratio. If plasma aldosterone and renin ratio is elevated more than usually 20, then you need to do aldosterone suppression test. If it is negative, then evaluate for other cause. If it is positive, then you should go for adrenal imaging. So first AR, then AS, then AI. Like first AR, what I am going to mean that first aldosterone renin ratio, then AS, aldosterone suppression test, then AI, like adrenal imaging. In adrenal imaging, if normal CT or age more than 40 with abnormal CT, then you need to do adrenal venous sampling. In adrenal venous sampling, if it is unilateral adenoma or hyperplasia, then go for surgery. If it is bilateral, if it is bilateral adenoma or hyperplasia, go for medical therapy. Okay. In adrenal imaging like AI, if there is discrete unilateral adenoma and age less than 40, go for surgery. So this is the thing you have to remember. So in primary hyperaldosteronism, if you read the explanation now, in primary hyperaldosteronism should be suspected in any hypertensive patient with hypokalemia. So primary hyperaldosteronism should be suspect in any hypertensive patient with hypokalemia. Patients with mild hyperaldosteronism may not have spontaneous mild hyperaldosteronism may not have spontaneous hypokalemia, but they are prone to develop diuretics induced hypokalemia. Diuretic induced hypokalemia. Severe hypokalemia can cause muscle cramp or weakness. Other things, metabolic alkalosis and mild hypernatremia. Patients usually do not have peripheral edema due to spontaneous diuretics. So they do not have edema due to spontaneous diuresis like aldosterone scheme. The best screening is early morning plasma aldosterone concentration to renin ratio. Plasma aldosterone to renin ratio. That however drugs that significantly altered plasma aldosterone concentration by plasma renin ratio is spironolactone, eplerenone, amiloride, triamterene should be withdrawn for 4 weeks. These drugs should be withdrawn 4 weeks before the testing. If plasma aldosterone concentration or renin ratio more than 20 with primary aldosterone more than 15 suggests primary hyperaldosteronism and patient requires further confirmatory adrenal imaging testing. If adrenal suppression testing usually involves salt loading and documenting the inability to suppress the serum aldosterone, patients with positive adrenal suppression testing should be undergone adrenal imaging, usually by CT scan. Oh, again, mm, positive, po- it does not suppress. Yes, because what we are suspecting via CT scan, we are suspecting for like adenoma or any sort of tumor, adrenal adenoma or adrenal producing tumor. You cannot suppress the tumor by giving the something, isn't it? So, so hyperaldosteronism is most commonly most commonly due to bilateral adrenal hyperplasia or aldosterone producing adenoma. If CT scan does not reveal a discrete unilateral mass, adrenal vein sampling is recommended to differentiate hyperplasia from adenoma. If CT scan does not reveal, surgery is preferred for adenoma and medical therapy is preferred for hyperplasia. Got it? Okay, now when we do chest CT can diagnose lung cancer, which can sometimes be associated with SIADH or Lambert-Eaton syndrome. Lambert-Eaton syndrome usually presents progressively worsening proximal muscle weakness, fatigue, ptosis, autonomic dysfunction, dry mouth. SIADH causes hyponatremia instead of hypernatremia. Choice B, like dexamethasone suppression test we know for Cushing, and 24-hour urinary potassium excretion was previously to document inappropriate potassium excretion. A 24-hour urine potassium more than 30 in the presence of hypokalemia suggests hyperaldosteronism. But this test is no longer commonly used and plasma metanephrine is for pheochromocytoma. Okay, like I don't actually know how it is done, so I cannot say you elaborately. Yes, yes, this adrenal venous sampling. If you take a sample from the adrenal gland, then you can see the full histological picture. Like, is it hyperplasia or is it cancerous? Like, if you want to see the histology, because sometimes hyperplasia may looks like cancerous. When we do biopsy, when we do histopathology and biopsy, then we can confirm. So this is the thing. I think that the venous part of the adrenal gland is cut off. Look at the Gemini, give the adrenal venous sampling and see what is adrenal venous sampling. You should always go for looking, like you can use Gemini, you can use others. You you tell the Google to see some picture, like then we can easily differentiate. Like ask Gemini to see the how procedure of adrenal venous sampling, how it can be done. Some pictures, just add some word in the Gemini, then it will tell something more. So what you got? Yes. I think that it's HCM. Maybe. Concentric left ventricular hypertrophy, isn't it like hypertension and AR and AR and MR, and HCM has multiple cause. Okay, wait. Go with your flow. Okay. So these patients, so concentric, acroncentric, acroncentric. Okay. Acro. Concentrate. Okay. I am trying to remember the concentrate. Okay. Because this thing, if you do 100 times of the world, you cannot remember. These are the things that you need to find out the way to remember. Because I just after 1 month, if we do the same question, then you will again gonna confuse. Okay. Even there is cardiomyopathy too. So what kind of cardiomyopathy it does? Concentric. Okay, I'm reading now. Okay. So this patient with characteristics manifestations of acromegaly. This patient character manifestation of the acromegaly including mm, coursing of facial feature, pharyngeal crowding, and enlargement of hands and feet. Acromegaly is caused by excess secretion of growth hormone, usually from pituitary somatotrope adenoma. Growth hormone increases the hepatic production of insulin like growth factor 1, which cause excessive growth of bone and tissue, leading to clinical manifestation of diseases. In the heart, acromegaly causes concentric myocardial hypertrophy leading to diastolic dysfunction. Eventually, this may lead to left ventricular dilatation and systolic dysfunction with global hypokinesis. The cardiomyopathy is worsened by concurrent hypertension, obstructive sleep apnea, and valvular heart disease, which is common. So concurrent hypertension, OSA, and valvular heart disease is common in acromegaly. Complications include heart failure, dyspnea, crackles at bases, and arrhythmia. Crackles at bases and arrhythmia. Cardiovascular disease is the leading cause of death. Cardiovascular disease is the leading cause of death in patients with acromegaly, but the normalization of the growth hormone levels following successful treatment markedly reduce cardiovascular mortality. Cardiovascular mortality. Okay. Option B, hypertrophic cardiomyopathy. A congenital cardiomyopathy that should be distinguished from myocardial hypertrophy and caused by cardiovascular disease, hypertensive, valvular, or ischemic is characterized by asymptomatic thickening of the interventricular septum, leading to left ventricular outflow tract obstruction, diastolic dysfunction, mitral regurgitation. It would not explain the features of acromegaly seen in this patient. Okay. Hello, 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 hello. It is stress induced hyperglycemia, so we do not give treatment. Okay, so stress hyperglycemia, transient hyperglycemia without pre-existing diabetes, intensive care unit admission, fever, sepsis, severe infection, major trauma or hemorrhage, and hypoxemia. Minimization of glucose in IV fluid, insulin to maintain blood glucose. Insulin to maintain blood glucose at 140 to 180 milligram per dl. So this patient elevated blood glucose but a normal HbA1c, no chronic hyperglycemia in the context of major trauma. This presentation is consistent with stress hyperglycemia. Stress hyperglycemia is a transient elevation in the blood glucose caused by metabolic stress in patients without pre-existing diabetes mellitus. It is common in the intensive care unit and is typically seen in patients with sepsis, burn, major trauma, hemorrhage. Severe stress triggers the release of cortisol and catecholamine, which act on the liver to increase glycogenolysis and gluconeogenesis, an effect that can be enhanced by glucagon. The free glucose is then released from the liver into the blood. Mild glucose elevations, such as in this patient, are generally considered to be an adaptive physiologic response and do not warrant intervention. However, severe elevation more than 180 to 200 milligram per dl are associated with increased mortality and should be corrected with short-acting insulin in most cases. A mildly elevated target blood sugar 140 to 180 milligram per dl is recommended to minimize the risk of insulin-induced hypoglycemia. Okay, non-fasting is higher, isn't it? It is like postprandial hyperglycemia. Wow. Yes. Okay. So this one is important. Okay. Now, so progressive in therapeutic intensification in type 2 diabetes mellitus. First, metformin, preferred initial therapy, then metformin plus oral antidiabetic agent, GLP-1 analog, or basal insulin, then basal bolus insulin. So you have to uh, move up while you are treating the patient with diabetes. Okay. HbA1c reflects the average glucose level over the lifespan of hemoglobin, about 3 months, and should be less than 7% for most patients with type 2 diabetes mellitus. HbA1c is influenced by both fasting and postprandial glucose concentration. Fasting and postprandial glucose concentration. These patients' HbA1c is elevated despite appreciable morning fasting glucose. She has markedly she has markedly elevated non-fasting glucose more than 290 milligram per deciliter. Therefore, this patient likely has frequent postprandial hyperglycemia leading to impaired overall glucose control. Management requires better control of postprandial hyperglycemia without inducing fasting hypoglycemia. The goal can be generally achieved through basal bolus regimen. Basal is insulin glargine, supplies a steady influx of insulin which maintains fasting glucose control through suppression of hepatic gluconeogenesis. And rapid acting insulin aspart, is typically given just before meals. It peaks within 15 to 30 minutes. It peaks within 15 to 30 minutes and control postprandial hyperglycemia. These patients already control fasting glucose, suggest adequate basal insulin coverage to adequately treat her postprandial hyperglycemia. Rapid acting insulin should be added. Okay, the dawn phenomenon. The dawn phenomenon causes early morning fasting hyperglycemia, 2 to 8 a.m. fasting hyperglycemia due to circadian increase in growth hormone and cortisol secretion in many patients. It can be managed with basal insulin dose. These patients' suboptimal glycemic control results in inadequate postprandial control rather than early morning hyperglycemia. Her fasting glucose is taken in the morning is within the normal level. So dawn phenomenon is early morning fasting hyperglycemia due to the circadian increase of growth hormone and cortisol secretion. So growth hormone and cortisol secretion causing increased glucose. We know that if there is increased glucose, there is decreased growth hormone, isn't it? If there is, if we think it in the reverse way, like if there is increased growth hormone, then what will happen? So why? So it is not on that way. Okay. Okay, this does not match. Okay, so this patient has early morning hyperglycemia or like fasting hyperglycemia due to circadian increase in growth hormone and cortisol. It causing increased glucose. That's why there is hyperglycemia. Okay, okay. Insulin neutralizing antibodies. Increase insulin neutralizing antibodies against exogenous insulin may be suppressed when a patient has fasting and non-fasting hyperglycemia despite high very despite very high insulin dose. These patients fasting glucose is adequately controlled with basal insulin. In general, insulin neutralizing antibodies are rare when a recommended insulin analog glargine is used. but was more common in the past with bovine and porcine insulin. Got it? Is it pancreatic cancer type? Yes. There is no early satiety for 3 month abdominal discomfort after eating. Okay, I may not be right. Um, GERD does not cause 5 kg weight loss. Uh, Diabetes, gastroparesis. Yes, it can happen. Uh, GI motility drugs, metoclopramide can be given. Domperidone usually, you are confirmed it is gastroparesis, nausea, vomiting, early satiety, abdominal discomfort, especially after eating, relief after vomiting and undigested food. Weight loss, maybe gastroparesis. He has long, um, I think that metoclopramide can be given for gastroparesis. Okay, initially I was a bit confused with the fatigue and early satiety. Sorry. Okay, I imagine the fatigue. Okay. Okay. Gastroparesis. Causes of gastroparesis like diabetes mellitus, medication, diabetes mellitus medication, opioid and anticholinergic drugs, trauma post-surgery, vagus nerve injury, neurologic, multiple sclerosis, spinal cord injury, and idiopathic post-viral, nausea and vomiting, epigastric abdominal pain, early satiety, bloating, weight loss, labile glucose, diabetes mellitus, epigastric distension and succussion splash. Diagnosis, exclude obstruction, upper endoscopy, CT or MR enterography, and assess motility, emptying study, nuclear gastric emptying study. Treatment frequent small meal, low fat, soluble fiber only, pro-motility drug, metoclopramide, and erythromycin, and gastric electrical stimulation, and or jejunal feeding tube, refractory symptoms. This patient has symptoms suggestive of diabetic gastroparesis is a syndrome characterized by delayed gastric emptying in the absence of mechanical obstruction, chronic hyperglycemia in patients with uncontrolled diabetes, elevated HbA1c in this patient may lead to autonomic neuropathy, which causes uncoordinated smooth muscle contraction, and ineffective gastric motility. This slows the rate at which food leaves the stomach, often causes nausea and postprandial emesis, early satiety, bloating, abdominal pain. In severe cases, weight loss can occur as in this patient, although not diagnostic of the gastroparesis. Upper endoscopy may reveal food in the stomach despite an overnight fast. After ruling out of mechanical obstruction performed in this patient with upper endoscopy, the diagnosis can be confirmed with gastric emptying scan. Treatment of gastroparesis include optimization of glycemic control, dietary modification, smaller, more frequent meals, and decreased fat and insoluble fiber intake, and medication that improve gastric emptying. Metoclopramide has both prokinetic and antiemetic properties that relieve symptoms of gastroparesis. Although often effective, it is associated with small risk of extrapyramidal adverse effect dystonia and tardive dyskinesia. Other options include erythromycin, whose use is limited by tachyphylaxis, and domperidone, which rarely causes cardiac arrhythmia, and QT prolongation and hyperprolactinemia. Okay. It's not rickets, and there is no bowing or this. Which vitamin? Maybe vitamin D deficiency, uh, or C. Vitamin C is scurvy. This causing he he's pasteurized breast milk obtaining from local. It is vitamin deficiency, isn't it? Is it vitamin D deficiency? Because why I have said, like, in the breast milk there is poor vitamin D, but in the cow milk there is high vitamin D. So in case of children, uh, if the patient is breastfeeding, you should give vitamin D and iron as well as a supplement. Okay, so what has told in the X-ray? Okay, in X-ray there is metaphyseal concavity. Look at the X-ray first. Metaphyseal concavity and indistinct margin. Metaphyseal indistinct margin. Okay, okay. Nutritional rickets. Okay, nutritional rickets is caused by deficiency of vitamin D, which is necessary for calcium metabolism. Risk factor include limited sun exposure, increased skin pigmentation, and exclusive diet of breast milk without vitamin D supplementation, as in this infant, is a major risk factor, or because breast milk alone contains inadequate vitamin D. Deficiency of the vitamin D and calcium leads to poor bone mineralization and accumulation of the growth plate cartilage. Infants may have Infants may have craniotabs, skull bone depressed skull bone depressed with pressure, as seen in this patient. Skull bone decreased in pressure, as in this. Where? Okay, widened wrist may be present due to growth plate enlargement. Widened wrist may be present due to growth plate enlargement. Additional findings include radial or ulnar bowing and delayed frontal closure. Lower extremity bowing is apparent once children become weight bearing. X-ray of the rapidly growing skeletal areas, wrist, knee is helpful diagnostic tool. X-ray findings include metaphyseal widening with cupping and fraying, as seen in this patient, and costochondral joint widening is also classic. Treatment include vitamin D and calcium supplementation. Next, dorsal column, dorsal column pathology. He has diabetes. Uh, and diabetes causes axonopathy of which fiber? Or this, my Diffuse demyelination of the nerve fibers of the lower extremity. Demyelination. L- Okay. Large fiber neuropathy causes these. Okay. Okay, I'm reading the box first. Large fiber neuropathy and small fiber neuropathy. Large fiber for dorsal column like pressure, vibration, fine touch, proprioception, balance, and small fiber for pain temperature like lateral spinothalamic tract. Okay, so large is dorsal column, large dorsal column, and pressure, vibration, fine touch. Okay, major symptoms is numbness and poor balance, numbness and poor balance, and examination finding diminished or absent ankle reflex, and reduced or absent vibration and light touch and proprioception, reduced or absent vibration, light touch, proprioception. And in small fiber it causes burning and stabbing pain. There is reduced pinprick sensation, reduced pinprick sensation, and ankle reflex possibly preserved. Okay, so for small fiber, real there is burning, stabbing pain, and small fiber like pain and temperature. In small fiber, just pinprick is reduced. But for large fiber, dorsal column like pressure, vibration. So we need to do the tuning fork test. We need to see the touch and absent ankle reflex. Okay, diabetes mellitus. Diabetes mellitus is the common cause of peripheral neuropathy, which with the risk related to the duration of the disease and glycemic status. With neural injury in diabetes is due to a number of factors, including microvascular injury, demyelination, oxidative stress, and depletion of the glycation end product. The use of metformin, which decreases the use of metformin, which decreases the intestinal absorption of the vitamin B12, can also contribute. This leads to length-dependent axonopathy, and clinical features occurring in the first longest nerve. Symmetric distal sensorimotor polyneuropathy. Symmetric distal sensorimotor polyneuropathy is the most common neuropathy in the patient with diabetes. The clinical feature depend on the type of the nerve involved. Small fiber injury characterized by predominance of positive symptom, pain, paresthesia, allodynia, and large fiber causing negative symptoms like fiber like negative symptoms, numbness, loss of proprioception, vibration sense, and diminished ankle reflex. Uh, Allodynia may be abnormal pain sensation if like more pain sensation maybe. Yes, it's pregabalin. You can give amitriptyline, but there is a problem. He has coronary heart disease, coronary artery disease with non-ST elevated MI 4 years ago. So if somebody has coronary artery disease, you should give cholinergic, anticholinergic drug with caution. Like you should not give. Got it? Okay. Uh, what are the drugs? First, what are the drugs for neuropathic pain? Tricyclic antidepressant SNRI, duloxetine, decreased reuptake of serotonin and reuptake inhibition of pain signals. Anticonvulsant, gabapentin and pregabalin, decreased depolarization of the neuron in the CNS. Opioid activation of central opioid receptor, capsaicin topical, loss of membrane potential in nociceptive fiber, and lidocaine, decreased depolarization of neuron in the peripheral nerve. So this patient with uncontrolled diabetes mellitus with a HbA1c, elevated H1C has neuropathic pain, asymmetric distal neurologic deficit, loss of reflex, altered vibration and proprioception, and consistent with sensory motor polyneuropathy due to sensory motor polyneuropathy due to diabetes. The clinical features of a diabetic neuropathy depend on the type of the nerve fiber involved, and small fiber neuropathy causes pain, allodynia, paresthesia, whereas large fiber involves numbness, proprioception, diminished vibration sense, loss of ankle reflex. Both the fibers can commonly seen together. Both types are commonly seen together. As diabetic neuropathy progresses, the pain may diminish, but the sensory deficit persists. Initial treatment with symptoms. Initial treatment of option for painful diabetic neuropathy include TCA, dual serotonin, norepinephrine, reuptake inhibitor, duloxetine, and anticonvulsive pregabalin, gabapentin. Pregabalin is a structural analog of GABA, a gamma amino butyric acid that decreases pain by inhibiting the release of excitatory neurotransmitter binding to voltage gated calcium channel modulator on the nerve terminal. Common side effect is drowsiness, weight gain, and fluid retention. Okay. Isn't it Cushing? Yes. Chronic glucocorticoid therapy causes adrenal insufficiency. Which kind of? So in here cortisol will be low and ACTH is low too. No, yes, and aldosterone is normal because BP is normal. If aldosterone is low, BP is kind of very low. Okay, it's secondary. Okay, if we look at the box, in primary there is destruction of bilateral adrenal cortex. In secondary there is disruption of hypothalamic pituitary stress. In primary autoimmune adrenalitis and infection malignancy. In secondary adrenal insufficiency, there is chronic glucocorticoid therapy, infiltrative disease, and ischemia. Chronic glucocorticoid therapy, infiltrative disease, and ischemia of the anterior pituitary gland. In primary, we know that cortisol will be low, aldo will be low, and ACTH will be higher. In secondary, cortisol is low, ACTH is low, but the aldo is normal. In primary, the clinical feature more severe symptoms: hypovolemia, hyperkalemia, hyponatremia, hyperpigmentation. And in secondary, severe or less severe symptoms: euvolemia, minimal electrolyte disturbance, and no hyperpigmentation. Okay. Yes. The patient who has nausea, weakness, and fatigue following abrupt discontinuation of the chronic glucocorticoid therapy is secondary most likely secondary adrenal insufficiency, which results from disruption of the hypothalamic pituitary axis. Chronic use of exogenous glucocorticoid prednisolone suppress the secretion of both corticotropin releasing hormone from hypothalamus and ACTH from the anterior pituitary gland. On abrupt discontinuation of exogenous glucocorticoid, the pituitary gland must be unable to increase ACTH secretion to meet evidence to meet the metabolic events for up to 6 to 12 months, resulting in secondary AI. Any patient who receives chronic glucocorticoid for more than 3 weeks is at risk of developing secondary adrenal insufficiency, with the risk of increasing in those who have longer treatment duration and those who have Cushingoid face, facial plethora, supraclavicular fat pad. The diagnosis of secondary adrenal insufficiency confirmed by measuring of low hormone cortisol and CTH. Because aldosterone secretion from the adrenal cortex is mediated by the angiotensin II rather than the ACTH, aldosterone level are normal with uh, secondary AI. Mild hyponatremia may be present, but cortisol deficiency can increase antidiuretic hormone secretion, However, electrolyte abnormalities in secondary AI are typically minimal. Next, if radioiodine uptake or scan show decreased uptake, then the next, sorry, yes, it's not Graves. Graves will increase uptake, diffuse but increase, not decrease uptake. So for diagnosing decrease uptake, you need another test. Yes, you need to do thyroglobulin. If thyroglobulin is low, it is exogenous. If thyroglobulin is high, it is thyroiditis and iron exposure. Okay, I am reading the box first. For evaluation of the hyperthyroidism, measure T3, T4, TSH. If T3, T4 high, TSH is low. If T3, T4 high and TSH is low, it is primary hyperthyroidism. If T3, T4 is low, TSH is also, sorry, in secondary hyperthyroidism, both are high. T3, T4 is high, TSH is high. Okay, if you get primary hyperthyroidism, then the next thing we need to do the signs of the Graves disease. Signs of the Graves disease, goiter and ophthalmopathy. If goiter and ophthalmopathy is present, then it is Graves disease. If no, there is no goiter and ophthalmopathy, then radioiodine uptake scan or radioiodine uptake or scan. If it is yes, radioiodine uptake is higher, diffuse uptake, that is Graves, and if it is nodular uptake, then thyroiditis. Nodular uptake, then toxic adenoma or multinodular goiter. If radioiodine uptake is low, then measure serum thyroglobulin. If serum thyroglobulin is high, it is thyroiditis or iron exposure. If it is low, then exogenous hormones. Exogenous hormones. Okay. Mm, Now, this patient has fatigue, sweating, palpitation, weight loss, has features of hyperthyroidism. The first step evaluating hyperthyroidism is to measure serum TSH and free T4 level. In the absence of TSH secreting pituitary adenoma, secondary hyperthyroidism, patients with hyperthyroidism have an elevated T4 and suppressed TSH. The most common cause of hyperthyroidism is Graves' disease and is caused by autoantibody to the TSH receptor and is characterized by a diffuse goiter and ocular abnormality, proptosis, periorbital edema. Patients with clear features of Graves' disease. Patients with clear features of Graves' disease may be managed accordingly, but those who require further investigation. Patients with undiagnosed hyperthyroidism may be evaluated further with radioactive iodine, usually with scan. A high radioiodine uptake suggests de novo hormone synthesis due to Graves' disease, diffusely increased uptake or toxic nodular goiter, nodular uptake. In contrast, low radioiodine uptake either release preformed hormone, thyroiditis, or exogenous thyroid hormone intake. In such case, the serum thyroglobulin level can make the distinction. Even thyroglobulin is consistent. Elevated thyroglobulin is consistent with exogenous thyroid hormone release, whereas decreased thyroglobulin suggests exogenous or factitious thyroiditis. Okay. In this patient, it is likely her weight loss supplement contains thyroid hormone derived from porcine or animal sources. Got it? Next. I think that C. There are some people, and in Bangladesh it is very common. You, like when they saw low blood glucose, they actually decrease the blood glucose. They actually decrease the insulin dose. I'm not taking, I'm not, uh, I'm just telling him to think. Do you think that that is happening with you? And in our country, we actually scold the patient that why you have done it. You are the criminal. Yes, truly, you don't know. Okay, has this patient has good glycemic control on a multi-dose regimen, but experienced loss of control after a severe episode of hypoglycemia. Patients with a diminished glucagon response Patients with a diminished glucagon response, such as those with pancreatogenic diabetes, chronic pancreatitis with fibrosis on the islets, can develop rapid and severe hypoglycemia with little warning. Such episodes can lead to confusion, seizure, and loss of consciousness and can be fatal. Mm, Even with mild hypoglycemia can be distressing due to associated autonomic activation, which can induce anxiety, tremor, palpitation, and sweating. Frequent and severe hypoglycemia can encourage behavioral change to prevent recurrence, such as increased caloric intake leading to weight gain or reduced adherence to insulin management. In the light of this, it helps to ask patients in a non judgmental manner about behavioral change, reducing insulin dose they may be that they might be making to avoid hypoglycemia. Management strategies include less stringent glycemic target, flexible insulin regimen, and prescription of euglycemic glucagon kits. Next. Yes. And the mother has gestational diabetes mellitus. Yes. We will see the glucose level. They haven't said that glucose is abnormal. We need to see the glucose level, but eh, because you have said like as the mother is diabetic, so baby is making lots of glucose and lots of insulin, and in uh, diabetic mother patient, diabetic patients babies are um, big baby, so weight is 4.2 kg, so you need to see the glucose. uh, is it going down? Yes. Pulse oximetry, if the saturation abnormality, his saturation is normal. Okay, infants of diabetic mother are increased risk of a variety of complication because glucose is actively transported across the placenta to the fetus. Excessive maternal hyperglycemia leads to fetal hyperglycemia. The effect of fetal hyperglycemia vary depending on the development stage of the fetus. First trimester, the fetus cannot produce insulin. The fetus cannot produce insulin. during the first trimester and therefore cannot protect itself from hyperglycemia. Hyperglycemia during the first trimester can disrupt organogenesis, resulting in malformation, congenital heart disease. Infant whose mother have gestational diabetes are not are, are, uh, are not increased risk for malformation because of maternal and fetal hyperglycemia does not develop until the organogenesis is complete. So in second and third trimester, once the fetal pancreas is sufficiently developed, hyperglycemia triggers the release of insulin, which results in normal glycogen and results in increased glycogen and fat storage, organomegaly, increased growth factor production, macrosomia, or birth weight more than 4 kg, and increased oxygen consumption, polycythemia. Okay. And infants of diabetic mother who are macrosomic are more difficult to deliver vaginally, leading to higher rates of cesarean delivery due to failure to progress, and operative vaginal delivery, forceps vacuum, and clavicle fracture, brachial plexus injury, asphyxia are associated with macrosomia. After delivery, fetal insulin production takes time to decrease, whereas maternal glucose exposure ends as soon as the um, umbilical cord is clamped. These often results in period of neonatal hypoglycemia. These often results in a period of neonatal hypoglycemia until insulin level normalize. Hypoglycemia is the most common complication among the IDN. Yes. Risk of clavicle fracture is increased in macrosomic infants such as in these patients. However, the normal Moro reflex makes the clavicle fracture unlikely. Infants exposed to hyperglycemia in the first trimester as a result of poorly controlled pre-pregnancy diabetes are at higher risk for congenital malformation, including microcolon. However, this mother has a gestational rather than pre-pregnancy diabetes, so this infant is not increased risk for congenital malformation. Uh, and risk factor for congenital hearing loss for congenital cytomegalovirus and patient's history of hearing loss. Insulin IDMs are not increased risk for hearing loss, although the infant should receive hearing screening as recommended for all newborn. Okay. Excessive thirst and urination looks like polyuria. Okay. Now look at the serum sodium. If serum sodium is more than 145 and plasma osmolarity is more than 295, What is your diagnosis? It is AVP. Look, go to the first question. What we have done first, maybe. No, no, not the first. Uh, yes, yes, yes. This one, this one. Okay, look at the serum sodium. Serum sodium is more than 145 and plasma osmolarity is more than 295. Then it is AVP. Water deprivation test is not needed. So it is diabetes insipidus. So now you need the test to differentiate. Why? To differentiate, is it central or cranial diabetes insipidus or is it nephrogenic? If you give desmopressin and urine osmolarity increases more than 600, then if you if you after giving desmopressin, like after giving desmopressin, if the patient responds, then it is central, and if no non-responsive, then it is nephrogenic diabetes insipidus. So it is diabetes insipidus. Okay. Now I am sorry. The plasma osmolarity, yes, because apart from this, in here you can easily figure it out. But if they will give like primary polydipsia, then it would be very confusing. Got it? Okay, I am reading the causes of polyuria and dilute urine. Okay. In PP, primary polydipsia, it is ADH dependent, excessive water intake, ADH dependent excessive water intake. Etiology is antipsychotics and psychiatric conditions. In here, water deprivation causing high urine osmolarity. If you deprive water, there is high urine osmolarity. But in nephrogenic diabetes insipidus or central diabetes insipidus, there is low urine osmolarity. And response to desmopressin, look at the response to desmopressin. If you give desmopressin, if there is increased urine osmolarity, then it is central diabetes insipidus. But nephrogenic, there is no change, and primary polydipsia, there is no change. So this is the differentiating point. Got it? And the central diabetes insipidus, the causes are idiopathic trauma, pituitary surgery, and ischemic encephalopathy. And nephrogenic is lithium, hypercalcemia, hereditary, like aquaporin 2 mutation, AVPR2 vasopressin mutation. Okay, so this patient has high serum osmolarity and urine, high serum osmolarity and urine studies showing low osmolarity, urine studies showing low osmolarity, and specific gravity is likely has diabetes insipidus. Diabetes insipidus can be caused by either deficient antidiuretic hormone deficient antidiuretic hormone deficient ADH central or renal ADH resistance. Both central and nephrogenic are characterized by impaired water absorption and concentration of the urine, resulting in high urine osmolarity, polyuria, and dilute urine. In this patient, polyuria more than 3 liter 24 hours is suggestive of frequent urination and nocturia. If there is mild hypernatremia is present, the common finding is diabetes insipidus. The ongoing the ongoing water losses and maintenance a stimulus for compensatory polyuria and low urine osmolarity. If your urine osmolarity is less than 300 milliosmol per kg, and low urine specific gravity in the setting of high urine osmolality. More than 250 milliosmol per kg reflect an inappropriately diluted urine. Okay. Is estrogen decreases TSH level? Okay. So increase levothyroxine dose requirement. Okay. Okay. Increase. If we look at the box first, major drug interaction of levothyroxine, decrease levothyroxine absorption, bile acid binding region, um, cholestyramine, iron, calcium, and aluminium hydroxide, and PPI. PPI will decrease levothyroxine absorption and sucral fat. Increase TBG concentration, estrogen replacement OCP, and tamoxifen decrease TBG concentration, androgen glucocorticoid, and anabolic steroid, and increased thyroid hormone metabolism, rifampin, phenytoin, and carbamazepine. This patient has symptoms of menopause, including insomnia, vasomotor symptoms, hot flashes, decreased mood swing. In the absence of contraindication, history of breast cancer, tobacco use, first line treatment for severe menopausal vasomotor symptoms is estrogen based hormone therapy. However, a notable effect of thyroid a notable effect of thyroid metabolism, more than 99% of circulating thyroid hormone is bound to plasma protein, primarily thyroxine binding globulin. Estrogen upregulates the production of TBG in the liver and increase in estrogen activity. Pregnancy, OCP, and menopausal hormone therapies raises circulating TBG levels, causing a corresponding reduction in the Phe T4 and T3 level. Okay. So in patients with normal hypothalamic pituitary axis, lower Phe thyroid hormone level triggers a transient increase in the TSH release, leading to increased thyroid hormone production. until the additional TBG becomes saturated with thyroid hormone and free hormones are elevated. However, patients with hypothyroidism and independent of exogenous hormone are unable to increase the production to compensate for the increased TBG. Therefore, patients on thyroid replacement therapy who are prescribed oral estrogen require a compensatory adjustment in levothyroxine dose. Okay,